Hey there, folks. Good evening. Guess what time it is? Oh my gosh, we are 4 minutes past the top of the hour. That means I am running late. The doc is late tonight, friends. You are in the right place, and that is Fertility with Fink, live on Instagram, YouTube, Facebook, LinkedIn. We've got a couple of different Instagram feeds. This is New Life Fertility over here, and this is me, Randy Fink, MD, and it is a pleasure to see all my friends like we do every Tuesday evening at this time. Thanks so much for being here live from Pensacola, Florida. So the last couple of weeks, I've actually been at one of our satellite offices in Panama City, but in the last, for Thursday and Friday of last week, I was working with some my colleagues and friends at the Missouri Center for Reproductive Medicine, MCRM, in Chesterfield. That's just outside of St. Louis, and that is a wonderful place also to have a baby. I've been there doing some egg retrievals, so it was great to be with all my friends, and I go there once a month. But last couple of weeks was at our satellite office in Panama City. Back in Pensacola tonight, we did a whole bunch of egg retrievals here today, and I've been running around all day long, and so my hair looks messed up, and well, you know what? That's the reason why. Yes, that's right. I'm entitled to have a bad hair day, just like all the rest of us. I've been wearing a hat all day long. But you know, this is the place that I look forward to being every Tuesday evening. It is our happy place. It is our safe place. It's the place where we can talk about all those things that are meaningful to us and the things that come to our minds about making a baby, the things about having a family, the things about women's health, and the place, you know, that you can ask those questions that you just can't ask anyplace else. So happy to be with you tonight. Let's say hi to our friends. Brianna, nice to see you here this evening. We've got Rosa, who joined, looks like Zamina. Savannah, nice to see you this evening. Mimi Howes, you are the first to join on my Instagram tonight. Hi, Sharmila, nice to see you. Good evening. Kowser, a pleasure to see you as well. Looks like Brenna Choka, nice to see you here. Mrs. V, hello and good evening. So let's see if we can't dive into some questions here. The first question comes from Zamina, and the question is, can an abnormal embryo make a baby? And that's a very good question. Can it make a baby? Well, in most cases, abnormal embryos do not result in pregnancies, at least in IVF. Now, things are a little bit different in nature, and it's interesting, you know, kind of the way that happens in nature. In nature, an abnormal egg can be fertilized and create an abnormal embryo that will continue to grow. And that's what results in, let's say, babies with chromosomal problems, such as babies with Down syndrome. In the IVF process, more commonly what happens is that those eggs either don't fertilize, or if they do fertilize, they don't result in a pregnancy that will continue. They may result in an embryo that doesn't grow. They may result in an embryo that grows and then stops growing. But the odds of having a chromosomally abnormal live birth as a result of the IVF process are extremely low. Now, you may be talking about one other interesting scenario there, and that is an abnormal embryo by the standards of your PGT testing, PGTA. So PGT, as we know, is the situation where you grow your embryo up to the blastocyst stage. And a blastocyst is typically a day 5 embryo. And why does that matter? Well, a day 3 embryo typically has 6 to 8 cells. And those 6 to 8 cells are still trying to figure out how to divide, trying to know what to do. By the time an embryo grows to blast, by the time it becomes a blastocyst, it has 150 to 250 cells. In those 2 days between day 3 and day 5, it grows a lot. And by that time, it's become a little functioning metabolic factory. So we know that by that standard alone, the blastocyst has a higher probability of being able to get you pregnant. It's more likely to get you a baby. Okay, well, that's all well and good. With PGT testing, we take some cells from the outside portion of the embryo. That's the part that's going to become the placenta. And they test those cells, and we can tell whether we believe an embryo is chromosomally normal or not. And if that embryo is not chromosomally normal, well, that's another question, because the question is how accurate is the PGT testing? Well, PGT is said to be accurate most of the time, but certainly not all of the time. It's not a perfect test. So is there a possibility that you can have an embryo that is said to be chromosomally abnormal on your PGT testing that actually results in a baby? And the answer to that is yes. It's roughly about a 5% probability. And I know this is true because I have transferred embryos that are said to be aneuploid that actually resulted in a live birth with a normal baby. In fact, there was a lady a few years ago who transferred 2 aneuploid embryos because she didn't want to discard them. She wanted to place them back in her body. So she did, and the presumption was, well, you know what? We thought it wasn't going to work because they were aneuploid embryos. But as it turns out, both those embryos implanted, she came back to my office with her 2 absolutely normal, beautiful baby boys, twin boys from those 2 embryos. So yeah, it can happen. It's about a 5% probability that by the time an embryo says that it is aneuploid, that it is in fact euploid. Let's see, we got some people to say hello to. Hello to Zenny in Miami. Good evening, and thank you for being here as always. The Bama Gal in Mobile, my beautiful mother and her faithful companion. That is my dad sitting by her side in Mobile, Alabama, not too far from where I am now. Hi, Lexi. Nice to see you. And Tracy in Miami, thank you for being here. Sharmila says, her daughter is kissing me. Thank you, Dr. Fink, for this wonderful embryo to be my daughter. I'm so happy that I was involved in the making of that embryo that became your beautiful baby that you are holding in your arms, getting kissed from right now. Boy, that is really such a special thing. Gosh. Rosa asks, does the cervix usually respond to prostaglandin at induction for cervical ripening? And the answer to that is yes, it does, because in the body, when the cervix goes to be ripened, when the cervix gets ready to start opening up on its own, it's that same chemical in the body. It's that prostaglandin that results in the cervix starting to get there. So by using the medication, it's the same chemical that the body makes. We're just kind of trying to accelerate that process. So yes is the answer. So Rosa, you are probably getting pretty close to delivery time, aren't you? I think you're getting close to maybe 36 weeks, 37 weeks. I know for a while you had a breech baby, but I think your baby, hopefully that means that your baby turned if you're talking about induction now. So we will keep our fingers crossed for you for sure. Hey to Sheila, Fertility Friends Foundation, good evening to you, and my friend Amber in Gulf Shores, good evening. This is a very exciting week, Amber, is it not? It is it's IVF retrieval week, and I'll look forward to seeing you. I think it is tomorrow. All right, Styles family, good evening. Thank you for being here as well. Mrs. Villarreal says, I have a high-level mosaic embryo. What are the chances that will result in a live birth? I believe it's a segmental mosaic, but it's a large deletion. Okay, so a mosaic embryo, and without trying to get into too much detail because it does get a little bit confusing, but basically what we know is that a mosaic embryo is one that, we have 2 pairs of chromosomes. We have 46 chromosomes, or 2 pairs of 23 each. So that's 46. A mosaic is when there is some abnormality in one of those pairs of chromosomes. So not across the whole thing, but in part of it, in half that set of DNA. That's what a mosaic embryo is. And mosaics are, in most cases, especially in the face of a segmental mosaic, in most cases are said to more likely than not be normal embryos. They have a very high probability of actually giving you a live birth. Now, the times that I get concerned about transferring a mosaic embryo are in situations like trisomy 21 or trisomy 13 or trisomy 18, because those are chromosomal abnormalities that, if they are left to grow on their own, can really truly result in a live birth with a chromosomal abnormality. And even though that sort of thing doesn't happen very often, it theoretically can. So that makes me nervous. But even with a high level mosaic, it depends on how segmental that mosaic is, but the numbers report that even a segmental mosaic, a high level mosaic, has a higher chance of getting you a pregnancy in most cases than does an untested blast. So that's pretty good. A mosaic embryo is definitely not a throwaway embryo. Hi to Marianne and Victoria Lynn. Any advice? 14 days past Provera and no cycle. Okay, so what happens with Provera? Provera is that progesterone medication that we give you that is designed to induce a period. So what happens under normal circumstances in a menstrual cycle? Well, your ovary releases an egg. And that egg hangs out and waits to get fertilized. And if sperm comes along and fertilizes that egg, woohoo, you're pregnant. The brain says, great, do all those things that you do when you get pregnant. And if not, it says, we're not pregnant. Fine. Shut off the hormones, clean everything out, and we'll start again next month. And that's the signal to have that nice normal period. Well, if you don't release the egg, then you don't get the signal. And what the signal is the progesterone level that then drops off. So when we give you Provera, we're really doing the same thing. We're giving you a level of progesterone, which we're then taking away when you stop it. And that withdrawal of progesterone should result in what we call a withdrawal bleed. Now, you're saying that you took some progesterone and it didn't give you the period. So what the heck happened there? Generally, it's one of two things. Either one, there was an absorption issue with the oral progesterone. And that's why some clinics, instead of using the Provera tablet, will give you a shot. They'll give you a shot of the progesterone in oil, or PIO. When you get a shot of PIO, progesterone in oil, there is no question about how you're metabolizing it through your stomach and your liver. 100% it's going into your system, and that will do it if taking the pill did not. 14 days is a little long. 14 days is longer than I would expect for you to still not get a period after taking that Provera. So it tells me something else is going on. The other thing that can happen there is that if your estrogen level is not high enough in order to build you a lining in that uterus, then progesterone has nothing to do. Your level will drop off. Your body may think it's trying to slough something, but there's no lining there to slough. So my guess, it would be one of those two scenarios, Victoria. So I would say it's probably worth getting an ultrasound or checking some hormone levels and kind of trying to see what's happening, especially the ultrasound part, I would think, because let's see if your lining is thick enough that there's enough there to slough, is what I would say. Okay, Misha, good evening on the Facebook side. Misha says, I just had my egg retrieval yesterday in Pensacola. Oh, Dr. Rips did your retrieval instead of me. Well, that's a shame. You should have said hi while you were here. But nevertheless, I'm supposed to start suppression with Orilissa in November for a frozen embryo transfer in January. Is there anything else that I can add to the Orilissa as far as supplements for transfer? And the answer to that is yes. Excuse me. A little scratchy throat here. The answer is yes, Misha. So You are, I guess you have some endometriosis. And endometriosis means that you're going to have your Orilissa for suppression for 8 weeks before you do your embryo transfer. And so what else can you do? There are 5, really 6 medications. Actually, in your case, there's 7 medications, or not medications, actually supplements that I recommend for embryo transfer. The first, yeah, your BCL6 was positive, so we're saying this is endometriosis. The first is it's recommended that you're on 1,000 milligrams of vitamin C. If you have endometriosis, before embryo transfer, 1,000 milligrams of vitamin C is the recommendation. Prenatal vitamin, vitamin D, vitamin E, CoQ10, L-arginine. In your case, your vitamin C, and the other thing is omega-3, the fish oil. Now, I'd probably start for you on the vitamin C now. I'd give that a couple of months if you can, or at least so that you have that during that 8 weeks of taking the Orilissa. The other stuff you can really start in the, I would say, in the month before you do your FET, so kind of in December. But remember also, as far as that prenatal vitamin goes, you should be you should be on that. You should be on the vitamin with folic acid for at least 3 months prior to conceiving. So hopefully you've been taking a prenatal for a while there. See your question there, Amber. We will talk about that tomorrow. How about that? Marianne asked, how does insulin resistance affect an embryo transfer and what can help? Well, so there are 2 things that help with insulin resistance. And let's talk about what insulin resistance really means and how it affects us getting pregnant. Insulin resistance is one of the features that's associated with polycystic ovarian syndrome, but many of us have some evidence of insulin resistance just really based on our diets alone. So what happens with insulin resistance is that our bodies want to maintain a blood sugar level that is kind of within what we'll call a normal range, somewhere within here. So let's say you pop open a Coca-Cola and you drink it, and maybe just for good measure, you chase that with a Snickers bar. All right, what's going to happen to your blood sugar? It's going to go way above that level. It's going to come up to here. Well, what does the body do under that circumstance? We make insulin. Insulin is the hormone that brings down that blood sugar and wants to keep it back within that normal range. Insulin resistance occurs when we need more and more insulin in order to take that blood sugar and bring it back down and keep us normal. Diabetes, type 2 diabetes, happens when there's so much insulin required that you run out of room and basically your blood sugar is no longer able to stay in that normal range. Now it's at a steady state that's above that normal range. That's type 2 diabetes. So insulin resistance can have an effect. It has an effect on the ovaries. It has an effect on the eggs and on the maturity of the eggs and how those eggs get released. And it has an effect on implantation. And so really specifically as it pertains to implantation, folks who have significant insulin resistance, and that would be people with known diabetes, people with polycystic ovarian syndrome, may be at higher risk for having a miscarriage because of the effect of that higher blood sugar or of that insulin resistance alone on the lining of the uterus. And what can you do about that? Well, that's a great question. 2 things that you can do. Well, really 3 things that you can do. They say, first of all, well, if you lose 10% of your body weight, then that is going to have a dramatic impact on insulin resistance. But we all know that losing 10% of our body weight is not an easy thing to come by. So therefore, we treat that with medication, Marianne. We treat it with either metformin. And metformin is a medication that is used by folks with diabetes to keep their blood sugars low, but specifically as it pertains to insulin resistance, we use it with polycystic ovarian syndrome or anybody else who's known to have insulin resistance in the fertility world, because that will decrease the risk of miscarriage. Now, let's say that you don't want to take a prescription medication, because metformin does have some side effects. Metformin is bloating, gassy, diarrhea, nausea. It's all GI side effects. And kind of once your body gets used to it, it's not terrible. But until your body gets used to it, it can be no fun. There is another option, and that is a supplement that is called myo-inositol. Myo-inositol. You got to take a fair amount of it. It is 4 milligrams of myo-inositol twice a day for a total of 8 milligrams a day of myo-inositol, or just inositol. Now, I will tell you that if you go looking, there is something that's called dechiromyo-inositol, and that is a different animal. There is one brand of inositol that is called ovasitol, that is a hybrid of dechiromyo-inositol and myo-inositol, but in a particular ratio. I don't actually recommend that one. I recommend, the evidence is really better on just straight old myo-inositol. It's not as expensive. You just got to make sure that you're taking enough of it. And so that would be 4 grams twice daily. Inositol comes in 2 forms. It comes in a tablet, or a capsule form rather, but it also comes in a powder. And with the powder, you just got to mix it in with something. And quite frankly, I think it's gross. I think it's hard to drink powdered medication in a liquid and to really kind of choke it all down. So some people have no issue with it. For me personally, I would rather take a capsule. So that's what I would do. So if you're not on metformin, Marianne, I would recommend that you start on inositol. Hi to Florida Girl. Thank you for being here. Florida Girl asks, is it okay to start a modified natural transfer without a baseline? I've never done that before, but they can't get me in until next week, and cycle day 1 was today. In all probability, it's okay. Now, what do we look for when we do a baseline, and what could be happening in a baseline that could result in you not doing so well with an embryo transfer? Some people have a leftover cyst or a leftover follicle in the ovary that's still secreting hormone. And if that follicle is above, let's say about 14 millimeters or so, or let's say that your estrogen level is above about 100, then we start to think, well, maybe that's not ideal when it comes to doing embryo transfer. Now, in your situation, especially because you're talking about doing a modified natural transfer where your body's going to need to be doing its own hormonal thing, you run a risk there. But I would say, I think you're probably fine to start it. At worst case scenario, when you do go and get your ultrasound, which will probably at that point be after you've taken your letrozole, you may find that you have a big cyst in the ovary. And if that's the case, well, then you know what? You just hold off and wait another month. So we like to do baselines because we don't like to have issues. We don't like surprises. We want to know, really be able to control as many factors as we can. But if you can't do it, you can't do it. And I don't think that that's reason that you should say, I can't do a transfer this month. Hey, in a couple of minutes, we've got the 5:30 Fuzzies with Fink, so please don't go away. That's an important one if we can have as many people around to send those positive vibes out as we can. That would certainly be appreciated. So stick with us, couple of minutes away. Rosa says, is waiting until 40 weeks the due date okay if there's no preeclampsia or other problems, or should I induce at 39 weeks? You're 37 weeks now. Okay, I was thinking 36 weeks, 37 weeks, and the baby has turned head down. So that's awesome. A lot of times, babies that are breech or butt first will, in fact, turn on their own. And that's great. There's something else you can do. You can do what's called an external cephalic version, and that's where we physically try to turn the baby around. But great that your baby turned by itself. So when we talk about 39 weeks of pregnancy, technically what we're talking about is not necessarily just 39 weeks to the day. It is the completion of the 39th week, which means 39 weeks and 6 days, all the way up to 40 weeks. So the question is, should you induce your labor at 39 weeks, or should you wait until 40 weeks? Technically speaking, there shouldn't really be a difference in terms of outcomes as far as the baby goes. If your cervix is ripe enough, and yes, I say that for you, Melissa, a ripe cervix, sorry, Rosa, I had to throw in that aside, but if you say that your cervix is ripe enough or needs to be right or can be ripened, then there really is no extra risk to being induced at 39 weeks. But if you're uncomfortable with that, then, even if you wait until 40 weeks, you're at the end of that 39 weeks and you're at 40, I think that is just fine. And because you're 43 years old, that's one of the reasons I would say I would not want you to wait until 41 weeks. I would recommend between 39 and 40 weeks is a reasonable time to have a baby. There's nothing specifically about an IVF baby that requires you to have an induction of labor. So it is generally speaking safe to wait 39 to 40 weeks, but at 43 years old, I wouldn't want you to wait any longer after that. So it's 5:30, which means it's time for the Fuzzies with Fink. What the heck is that? Why does he keep saying that? The 5:30 Fuzzies with Fink is the time that we can all get together, that we can, as one community, stand together, hand in hand if we could. But how about mindfully or virtually, hand in hand, with our arms on, if not hand in hand, our arms on each other's shoulders, but sending the positive wishes, sending those good vibes out to everybody who could use a little bit of good vibe in their life right now. Some of that has to do with fertility. Some of you are going through fertility treatments. In fact, probably most of you watching right now are dealing with fertility issues. And it sure is nice, isn't it, to know that you have a friend on your side. Well, I'm here to tell you that you've got a whole bunch of friends on your side. And that is this wonderful community that joins into Fertility with Fink every week. The folks who watch this, the folks who participate. I think that every person here would do anything they could for any other one of you. So let's make that a reality. So Florida Girl, to you, to Rosa, to Amber for sure, especially tomorrow with an egg retrieval. Liz Carmen, to Kowser, La Mujer, Purple Butterflies, to Indepino Journey, it looks like there. It's Lala Official. Ariel, Faith, Hope, Love, Warrior, to Victoria, to Dr. J, to Dancer. Hey, nice to see you. Gradle, blessings on your way, to Marianne, to Victoria Lynn, to Zenaida, to the lovely Bama gal, Emily and Harold, to Lexi, to Tracy, to Sharmila, to Mrs. Villarreal, to Zamina, to Brenna, and to Mimi. And Melissa. Let's just say a very special bunch of warm-hearted love and greetings, mwah, to everybody. Send that vibe out right now. I feel like I'm like a tele-evangelist, but I really think there's something to this. Sending those vibes out to every single one of you from every single one of us. God bless. And that is the Fink Fuzzies at 5:30. Hey, participate next week if you couldn't do it this week. Get all your friends to come in, even if it's at 28 minutes after the hour and only staying until 2 minutes after halfway through. Because the more people we can have here to send out those positive vibes, the more those positive vibes are going to do. Because I think they make a difference. So thank you so much for participating there. Yep. And Alexis has her first ultrasound on Friday. You are 5 weeks today. So Friday. Okay. So listen, here's the thing to know, pardon me, about that ultrasound that you're going to have on Friday. Today is Tuesday, Wednesday, Thursday, Friday. That's going to be 5 weeks and 3 days. You ought to be able to see a pregnancy that is inside the uterus. You should be able to confirm at that point that you have an intrauterine pregnancy. But that's going to be a little bit too early to see the heartbeat. All right. So I just want you to know that the heartbeat typically starts at about 6 weeks. Sometimes we can see it a couple of days beforehand, maybe at 5 weeks and 5 days, but 5 weeks and 3 days, usually not. So don't expect to see the heartbeat when you do that, but probably a week or so later you will. Once you look and you see that heartbeat, 95% of those pregnancies will continue without having a problem. So Lexi, our thoughts are with you, my friend. Fingers crossed. All right, let's see. I had a bunch more question over here. Let's see. Faith, Hope, Love, Warrior. You had your FET today and it went smoothly, but the TSH increased since baseline. You're upping your thyroid medication. Any tips to lower that, and how often should I use vaginal probiotics during that time to wait? To be honest with you, I don't recommend that you use vaginal probiotics after an FET and before you're waiting to get that positive pregnancy test. There is no evidence that it's helpful, and I really just don't like putting other stuff inside because you don't know what kind of effect that's going to have. I do recommend that you use progesterone vaginal suppositories, but as far as vaginal probiotics to put things on the inside, there's just not enough evidence to say that unless you're treating something specific, that there's anything that is inherently wrong with your vaginal health that will result in a pregnancy not sticking. So I would say don't put extra stuff inside. That's my 2 cents worth there. Let's see. Rosa tells me I have a very good memory. Sometimes. Thank you. Oh, and by the way, Faith, Hope, Love, Warrior. We talked about the vaginal probiotics, but if your thyroid tends to fluctuate, and it kind of fluctuates a lot, and some of that may also really depend on what time you're drawing your blood relative to when you took your pill, and did you take your pill on an empty stomach? So you're supposed to take your pill on an empty stomach an hour before or 2 to 3 hours after a meal, and the optimum time to check your blood is 6 hours after you do the blood test. So a lot of times people end up chasing around these TSH numbers, but kind of that's what I do. There's really nothing else naturally that you can do that will affect or impact that TSH. So it sounds like your levothyroxine is the right choice there. Lala Official. Good evening, Miss Official. My Lupron suppression is wearing off, and my first transfer is on the 27th. Okay, that's in a couple of weeks, but I'm having symptoms of severe low back pain wrapped around my hips and some cramping. Would that interfere with my transfer? So, I got to tell you, the taking of Lupron is really hard. It's really hard. It has literally pulled the plug on your hormones, and that can lead to all kinds of side effects and symptoms. Joint aches and pains are really high up there on the list, as are, more obvious things like hot flashes, vaginal dryness, leg cramps, night sweats. So, I think that's a function of the medication. And what's going to happen in all probability is that when you're going to do embryo transfer, if you're doing a medicated cycle, then you're going to be starting back on some estrogen pretty soon. And you'll start back on estrogen, and that means that really those side effects and symptoms should start to go away. Things will get better there. So no, I don't think that is any reason that you should, that's going to end up postponing or causing some trouble with your embryo transfer. So our fingers are crossed there for you as well. Okay, Kowser says it's been a month since my egg retrieval and I haven't had a period yet. That is interesting. Is that normal after egg retrieval, or should I be concerned? Should I continue to wait or do I need to schedule an ultrasound and blood work? So usually what happens, like we talked about before, normal circumstances, ovary releases an egg. In your case, you had an egg retrieval. And so you got a trigger shot and you released all the eggs that were mature enough. But instead of being kind of just ejected into your body to be taken up by the fallopian tubes, they were retrieved. Meanwhile, you developed what's called a corpus luteum in every single one of those little follicles. And the corpus luteum is what makes progesterone. So you had your progesterone, you had a lot of progesterone in your body, presumably from every single egg or every single follicle that was retrieved. So it's kind of hard for me to imagine a situation where you didn't have a progesterone level that would drop unless you happen to conceive spontaneously on your own sometime in there. So I think that's probably a reasonable thing to do a pregnancy test. But sometimes maybe, what happened is that you just didn't build up enough lining. So when your progesterone level dropped, there just wasn't enough lining there to slough off. But that would be a lot more unusual as well. So I think that is definitely worth some follow-up. Interesting scenario. Plant Honeys, hello. And Belle Nashi. Hi to Kathy Hull. Wendy, thank you for being here this evening. So let's see. Pardon me for coughing. One of the things that I like to do when I'm doing an egg retrieval is I like to ask, well, so what music do you like? And most of the time, I'll tell you what, most people say, oh, I don't care. I really don't care. And I say, you know what? I bet you probably do care. You just don't want to express something. Yeah, you're not particular. Anything will be fine. But you know what? When you get put to sleep, when you get some sedation and you're in a stressful environment, I think it makes a lot of happiness to hear comforting music, the music that you like when you're falling asleep. And while you're sleeping, your brain is still listening. And as you wake up, to hear some of that same music. So if you're coming to see me for an egg retrieval, have an opinion. What kind of music would you like to hear? And we had all kinds of fun music today. Some people like Jimmy Buffett. Some people like worship music. Christian rock has been a particular favorite today. Some people like country music. Some people ask for Taylor Swift, and I will reserve a comment on that to all those Swifties out there. No offense, but yeah, actually, so we did listen to the album today, and it was okay. I didn't love it. Not that anybody cares about my opinion, but yeah, we heard a lot of different things. So, if given the option to say, what kind of music do you like to hear? Express an opinion, because I think it does make a difference in your outcome. How you go to sleep and how you wake up kind of does have something to do with the whole process. The other thing I wanted to talk about a little bit about tonight is stress. And this is something that we have addressed previously, talking about how people deal with their stresses. When we do that 5:30 fuzzies, it's not just about fertility. Maybe it's about health concerns. Maybe it's about family. Maybe it's about work or relationships. But life is full of stress. And people often ask me, is stress going to be a problem for me in my pregnancy? And I say, well, there's really not a whole lot you can do about it, right? Because there is no way to remove stress from our lives. We just can't do it. And people say, well, but my workplace is a stressor. So should I stop working? And I say the answer to that is, really probably not. We don't want you on bed rest in a pregnancy, because that's not a safe thing. It's not a good thing. Actually, you'd say, oh, that must be really good. If I'm on bed rest, then I don't have risks for, preterm labor and all kinds of bad things happening. And that's just not true, actually. Bad things happen to you on bed rest. We don't want you on bed rest. But can you take stress out of your life? And the answer to that is no. You can pull yourself out of a stressful environment. For instance, let's say that you're in a troubling relationship. You can pull yourself from that relationship, but that doesn't mean that the stress is gone. You can take yourself out of the workplace. And certainly, I would say if you are doing some kind of work where you're lifting heavy objects all day and every third day a forklift tries to run you over and there are problems in that regard. Yeah, maybe from a safety perspective, it might be better not to be in that environment. But what about the mean boss? Well, my boss is really mean to me and she really, expects, too much. And they're always, people bully me at work. Well, nobody should bully you. Bullying is not an okay thing. But, but were you to pull yourself out of that environment, do you think that that would resolve all the stressors in your life? My answer to that is really probably not. It might remove that one thing temporarily, but guess what happens when you're out of that job environment? You stop getting paid for that job environment. And if you think that doesn't add a stress to your life, well, it certainly does. I wish there was a good way that we could really absolve ourselves of stress, but we can't. It is inherent in the world. The question really is, what do you do with your stress? Do you allow your stress to eat you alive? Because if that's the case, if you let it, it's going to. And certainly I know sometimes it can get out of control. I think there are two things at play here. There is both depression and anxiety. Depression, I believe, in my humble opinion, is something that is related to thoughts or actions or things that have happened to us in the past and how we process those, what we do with that information. Whereas anxiety, for the large part, has to do with fear about what might happen tomorrow. Anxiety in the fertility world is extremely common because we don't know what's going to happen with your treatment. We can't predict what will happen when you do a therapy, ovulation induction, or when you do IVF, or what's going to happen here with how many embryos am I going to get? Are they going to be chromosomally normal? When I do my transfer, is the first one going to work? Those things do kind of plague upon us. But in pregnancy and in parenthood, the stress doesn't go away once you're out of the fertile time, because then every single day when you're pregnant, you wonder what's going on inside and you worry, because that's what good parents do. We worry about our children. Before long, your kids are born and you worry, is the crib good enough? Is the little mobile with all the bright, shiny objects and the music, is that good enough to stimulate the baby's brain? Are the diapers irritating him? Is she in pain when she's crying, or is she just lonely and wants some company? Then your kids got to start going to school, and you got to worry about school and all the other kids and all the sicknesses, and you got to worry about vaccines. And before you know it, they're dating, and you got to worry about who they're dating and where they're driving. And then you got to put them on your automobile insurance. And before you know it, they're going to college, and you wonder what they're going to do with the rest of their lives. So this whole process is, it is bedecked with worry and anxiety, because we just don't know the answers to all these questions. So what can you do with that? My answer is we try to take a mindful approach to what we're doing. And mindfulness is the act of just being aware of everything that goes on around us. So instead of walking outside and going and getting in your car and driving to work like you might normally do, take a couple of extra minutes Take a couple of extra minutes to listen to the sounds around you. Hear the cars moving. Hear the people in the distance talking, the birds chirping, or the squirrels squawking at one another. Hear the children playing. They say stop and smell the roses, and it's a little bit of a colloquialism. It's a little bit of a cliche, but that's really what it is. It's about taking the time to be aware of what's going on around you, hearing all those things, and experiencing your environment and the sensations that are happening in your own body. And those are the things that allow our minds to relax and not be as focused on all those anxiety provoking stimuli. So that's my 2 cents worth about mindfulness. There is another. I've mentioned this before. There's another app that I use that's called New Calm, Nucalm, New Calm, newcalm.com, and I can get you a discount. It's Sleep 15, SLEEP 15. We'll get you a discount on that subscription app. And basically what it is that it's a series of sounds that you listen to that reprogram your brain from the level of the brainstem, really the parasympathetic nervous system. It cranks that up, which turns down the sympathetic nervous system, which is our fight or flight response, and really can make a difference in the way you feel. Mindfulness and these kinds of activities to keep your brain away from focusing on all those stressors is really, I think, the best thing that you can do. Plant Honeys says, can you have a biopsy the same cycle as a frozen embryo transfer? My answer to that is no. I would say we don't recommend that you do that because we really don't want to touch that lining at all if possible. And what we're doing when we do have an endometrial biopsy, it's a little straw that goes inside the uterus and it sucks out a piece of tissue. It creates a little suction and it goes and it pulls a piece of tissue out. It's crampy when that happens because the uterus kind of goes, it kind of does that. It actually does make that noise, by the way. So that's an endometrial biopsy. You are disturbing that lining, and we want that lining to be as pristine as possible when it comes time for the transfer. It's not unheard of to have a hysteroscopy, to have a camera in to take a look, but I do not think that messing with or touching the lining is a good idea. Now, there used to be something that is called, and I mean, it's still around, it's called an embryo scratch, or an endometrial scratch. And the endometrial scratch was an endometrial biopsy that was performed in the cycle before you had an embryo transfer. And the thought was that by doing that endometrial scratch, that you would incite some kind of immune response that boosted the lining's ability to retain a pregnancy. Well, as it turns out, it's not really a thing. They've studied that very in depth and have found that the endometrial scratch does not improve pregnancy outcomes. There are still some doctors out there who, specialists who will recommend a scratch. It's a very old-fashioned kind of thing to do, but it doesn't feel real good, and the evidence does not support it. So I don't recommend it. But that's done in the cycle like day 21 to 24 or so, in the cycle before you do an embryo transfer. But I would not recommend that you do an endometrial biopsy during that same cycle. Let's see. Hi to Quick Draw, and Rachel Purple Butterflies says, does a saline sono on day 9 have any negative effects on a same cycle egg retrieval and fresh transfer? Yes, I would say it certainly can. So a saline sonogram is another way to evaluate the uterine cavity, and there's nothing wrong with it. So sometimes we'll do a hysteroscopy, and that's a camera that goes inside to look. Other times we can place a little straw inside and place a teaspoon or so of fluid inside the uterine cavity while we're looking with the vaginal ultrasound. And that shows us what's going on inside the uterus. Is there a polyp? Is there a band of muscle? Is there some scar tissue? Could there be something that's going on, what we call a filling defect? It would have no impact on an egg retrieval. And in fact, where I mentioned that I spent a couple of days last week at the Missouri Center for Reproductive Medicine, MCRM, they do a saline sonogram, or what they call a fluid ultrasound, pretty much on every person who is having an egg retrieval, to look for those types of filling defects. But that is not the case with a fresh transfer. If you are intending to do a fresh transfer, which is to say that you make your embryos and they go back in you the same cycle as you did that stimulation, or really the same cycle that they're born, you're putting an embryo in, I do not recommend that you do a saline sono. That would really not be the standard of care. Although, is it truly the end of the world for doing that? No, it's probably not the end of the world, but I will tell you that's not a standard of care, and I don't feel like that's really a very good idea. You could make an argument and say, well, look, I mean, that's on day 9, and you're talking about, 2 weeks later, at least, before you go doing an embryo transfer. So, what do you think the difference is? And the answer is, I don't know, because it's not a standard of care. So nobody's really going to study it. I just think you're really better off not touching that lining in a cycle where you're going to be putting an embryo in. Okay, let's see. Did we have a couple of other things here? Thank you, Amber, for laughing at my joke. At least somebody does. Oh, man. So let's see what else we got going on here. We are approaching the time of Halloween. And Halloween, I think, is an important time for us as a society. Why is that? Because, if you remember, when you were a kid, Halloween was, in all probability, really a very special time. You made a costume. Maybe a parent made a costume. Maybe you made it with your friend or a sibling. You made a costume, or you bought a costume. You got all dressed up. You got to go out. You got to go door to door with your friends or your family, and you got to collect huge mounds of candy, lots of sweet treats. Neighbors did fun things. People put up all kinds of very elaborate decorations for Halloween. People go all out really to try to make it a special time for the kids. Well, here's my 2 cents worth on it. We're not kids anymore, or at least most of us. Some of us still act like children, and what are you going to do? But you know what? Take the opportunity of Halloween to act like a child. Put some fun decorations outside, even if you don't want to dress up. And sadly, in my own neighborhood here, we don't get any trick-or-treaters. In fact, where I lived in Colorado before I came to Pensacola, there were no trick-or-treat. The houses were kind of far apart, and so maybe that was why. But there were some neighborhoods that were just absolutely loaded with kids. There were tons of kids and families and folks, serving witch's brew punch, full of special sauce for the adults, and sometimes even full candy bars for the kids. People would dress up. People would put, do big things in their yard, and really made it very special. Even if you're not a child, take this opportunity to make Halloween special, because you're making it special for somebody else's kid. It's going to make somebody happy, and it may just make you a little happier as well, because it's fun to do those fun kind of things. Yeah, it takes a little bit of effort, but how much effort does it take? So you know what? Go buy a bag of peanut butter cups or some little mini Snickers bars. Instead of just answering the door, go get a cowboy hat and get a little red bandana and tie it around your neck. And then suddenly you're not just a person answering the door with a basket of candy. You got a little Halloween costume on yourself. And I think that makes all the difference. Try to find things in this world to make yourself happy and to make other people happy. And that is kind of the lesson that I usually try to share at the end of my program. This is not the book of your life. Fertility is really just one chapter. And what are we doing? We are here to rewrite that chapter together. Every step forward with kindness, because the world is not a kind enough place. Do what you can to be kind to someone else. Smile at a stranger. Make them feel good. Make them wonder, why did he just smile at me? It's a nice thing to do. Do what you can. Every step forward with kindness. Every step forward with love. And every step forward, knowing that tomorrow is a new day full of all new adventures. And until next week, I'm Dr. Randy Fink from Pensacola. Thanks so much for being here. Good night.